So we can go live now.
Sure. Oh, good evening, ladies and gentlemen. Good evening from India. So, this is on duty because of our ongoing series of webinar with centers of excellence all over the world. Today, we have the privilege of having this with Professor Lang, whose center is very universally acclaimed. We all know him. He is a professor of medicine, director of non-invasive cardiac imaging laboratories at University of Chicago. He was the past president of American Society of Echo, and he is the lead author of a number of AC guidelines, and they are like a Bible to all our persons also. So he has been a very actively involved in the various sessions also. So universally claimed person. So now I hand over to Professor Lang to conduct his talk, and also then we'll call our speakers alternate wise or so. The audience can put up their questions in the chat box, and then but we will have our uh, if they need, we will have our discussion during in between. So Professor Lang, please.
So thank you so much, Satish, for inviting us for this webinar of the Indian Academy of Echocardiography. It's a great honor to be here and to share with you a little bit our experience on 3D echocardiography. And I will start today our initial talk by just giving you a little bit of a background of what are the advances in 2 and 3D echo in 2024 and 2025. I would remiss if I don't start these talks by always mentioning the father of echocardiography, Dr. Inge Edler. As you all know, he was from Sweden, and you can see that the technique of echocardiography was initially described in 1953. He was truly impacted by the use of sonars in the Second World War, and that's how here you can see Dr. Edler imaging the mitral valve with the anterior mitral valve on the right and the posterior mitral valve on the left. You see that little box that is the echocardiogram machine, and this is Dr. Edler making a demonstration in the American Heart Association. Now, 70 years later, this is how we image the mitral valve. So you can see that in 70 years, we have truly advanced tremendously in echocardiography. In the year 2007, we had the great honor of being the first place in the world at the University of Chicago, in which we did the first transesophageal echocardiographic study with a matrix TEE probe. Since then, we have seen that 3D echo has tremendously improved, and now we know about the advantages of 3D echo over 2D echo for the chamber quantitation, because it avoids foreshortening errors, and it also takes into consideration segmental dilatation. We have seen with 3D echo actually the first study ever of using AI, in which 3D echo a library of thousands of images were trained in a computer from which a generic model of the 3D was created and then adapted itself locally. But if you understand from this 3D chunk of data, the computer is capable of separating the different chambers from which quantitations of volume of both the left ventricle and the left atrium can now be performed. But you can see that as we move into the future, it will be possible to quantitate both the chamber volumes and the strains from 4 of these chambers simultaneously. From these endocardial reconstructions of the left ventricle, it is now possible to also calculate left ventricular shape. And this is a patient that has an apical and an anteroseptal wall motion abnormality. Over the last year, we have also been working heavily with the idea that if you combine blood pressure measurement together with an endocardial reconstruction of the left ventricle, it is possible to calculate a pressure volume loop from which the stroke work, the potential energy, systolic and diastolic properties can be obtained. So you can see how quantitation is improved. This has also spilled over to the right ventricle. I always like to show this image. This is an image in which we see the planes of 2D, how they intersect with a 3D of the right ventricle. And you can see how limited the 2D echo is relative to a 3D echo for the analysis of function. And you can see that now the right ventricular volumes and ejection fraction have become very reliable measurements of LV function. In the same way as we can use an AI model from the left ventricle, this can be also used on the right ventricle. And in about 10 seconds, you can, from this big chunk of 3D, calculate the 3D volumes. This is a paper, a figure of one of our papers, in which, just to show you an example of a patient with tetralogy of Fallot, pulmonary hypertension, atrial fibrillation, how we can also look at the different shapes of the right ventricle, as well as the shapes of the right atrium and the tenting volumes of the right ventricle. You can see how much you can find in patients with tricuspid regurgitation, atrial fibrillation. You can see how the left atrium is extremely dilated. The right ventricle maintains its shape, and you can see here that the tricuspid valve is stretched and doesn't have any tenting. Now, when you think about the three-dimensional acquisition, we talked a little bit about the acquisition, we talked about the analysis. Now I want to show you a little bit about what's happening with 3D echo in the interventional world. These are the types of images that we acquire routinely in a structural heart program. And you can see that many of these interventional structures or processes cannot be obtained if we do not have 3D echo. So this is something, and because of this, we can see that there's been a whole development of all different ways to quantitate, for example, in this example, the mitral valve, in which you can see here a prolapse of P2 and P1. You can measure actually the volumes of each part, the dimensions, etc., the angle between the aorta and the left ventricle. In this particular example, this is some work that we have been doing with some Italian engineers, and we can look at the regional stress of the ventricle. So in the last year, you all have seen the situation is that when we have a 3D image, we think about it as 3D, but we use it only because we are coloring things, and despite the fact that the image is in a flat screen. This is an idea that came by introducing a source of light into the 3D picture in order to create and augment the amount of shadows. And this type of shadows helps us create a 3D picture. And if you look, this is an example of a patient with a clip with an Alfieri stick. This is the regular 3D echo. This is now the 3D echo in which we have introduced the source of light. And here, in addition to the source of light, we have been modifying the texture and the transillumination of the surrounding tissue. And if you look here at the orifices, you can see how nicely we can delineate the orifices. And now, instead of this chunk, we can start seeing the clip exactly in its position. And these are some nice examples of now a left atrial appendage acquired with regular 3D echo. And this is now with the introduction of a source of light, the transillumination, and also the changing of the texture of the tissue. I'd like to pay your attention here to the pectinate muscles. This is this chicken wing configuration. And here you can very nicely see delineated the left circumflex artery. Well, we have over the last years learned how important it also is to image the tricuspid valve. 3D echo allows you to see the tricuspid valve all in one. And once you image these, you can see that many times, as you can see here, the tricuspid valve has 2 leaflets. And in this example, it has 4 leaflets. So if you look at this, you'll find all these different configurations that have been very nicely described by Dr. Becky Hahn, in which you can see 2, 3, and 4 leaflets. This is an example of a 3B. 3B is the second more common type, in which you have a septal leaflet, an anterior leaflet, and you can see that the posterior leaflet is divided into a P1 and a P2. So you have to pay attention to that, because this has an impact then for structural heart disease. We have learned also of the value of 3D echoes to look at the interaction between the tricuspid valve and the catheter. In this case, you can see impingement of the septal tricuspid leaflet, resulting in tricuspid regurgitation. Look at this same patient in 2D, it's very difficult to truly understand what is happening. This is another example in which, in this example, the lead is adhered or attached, in this particular example, to the posterior leaflet. And you can see in 3D echo how this leaflet is actually, the catheter is moving actually with the leaflet. I would like now to finish my talk by talking to you about something different, which is now we are trying to work on a way that we can show or display the 3D echo truly in 3 dimensions. So, people have used the glasses. We have used over the years monitors, which are very good, but yet very expensive. You have all seen the use of printing. This is one of our examples in which we see a cleft of the anterior mitral valve. The problem with this printing is that you can only print a structure in one moment of the cardiac cycle. And then we have, as you will see in other examples, a holographic display. Now, we have played over the last 2 years with the ability to take with virtual reality. Virtual reality has been used mostly in games, and there is a lot of industry behind it. In virtual reality, you can describe it as a computer-generated reality. When you put your mask, you don't see any real world. So we have a little lab in which we have found a way to convert a 3D echo into a virtual reality. We have a room that is equipped with sensors. We have a headset and controllers, and we have a computer. And this is us sort of playing with that. And just to give you an example, meaning when many of us went to medical school, this is the way in which we learned anatomy. We take our medical students nowadays, they actually learn anatomy. This is a clip taken from the Lerner School of Medicine at the Cleveland Clinic, in which all of the anatomy is now being learned using virtual reality. This is our view. This is at the American Society of Echo meeting. We had the first class of virtual reality in which we had 25 physicians all looking at the same anatomy, the same case, and our colleague explaining. You will, as you'll see in a minute, this VR will help you with education and training, communications with surgeons, and communications with patients. This is a 3D echo in virtual reality. You can see that using this handle, I can take this data set out of the computer and I can display it in the room as big as the room is. You can see that this bioprosthetic valve is stenotic. 2 of the leaflets are stenotic. And this is something that can be very nicely used. We're soon going to be playing, this is another way of displaying this, this is a virtual reality in which you take a 3D echo and you can make it float in front of you. You can see the clip, and then with your finger, you can start sort of cutting it and moving it. The operator can actually do that. This is a CT with virtual reality. As you go into the ventricle, you see the 2 papillary muscles. As I move into the left atrium, I can nicely see the pulmonic veins. And you can see that this is difficult to explain, but this is as big as this room. You could do a voyage inside the heart. Now this is flipped, and we're moving and watching the apex of the left ventricle. And this is sort of the new, this is a left atrial appendage. Watch with virtual reality in which we are making measurements. Interestingly, these measurements are not flat, as you can see, but follow the 3D structure. Once you have the measurements, you can actually choose the device that you're going to do, and you can place this device and see whether this device will seal the area perfectly well. So this is, I think, a very exciting thing about using VR to do the simulation of procedures. And this is a little bit the vision. We will be reading echoes. We'll have a list of studies. It takes about 5 to 10 seconds to change these 3D data sets into VR. You can take these out of the screen and visualize them. And you can see now on the lower left part the type of manipulations that are done in order to obtain these. We have the list of the studies that we're reading, and then you can obtain these, look at them, move them, put them back, and do whatever manipulation you can do. So I'd like to finish just to tell you that every time we think that 3D echo is done, we can see that the future is very bright and the future has arrived. And we, as I told you, have shown you that 3D echo is going to be extremely combined with artificial intelligence and with all these different types of modalities to improve our visualization of the heart to do structural programs. So with this, I would like to thank you very much for your attention. And I think Dr. Satish Parashar is going to introduce the next speaker, and then we will continue.
Thank you very much, Professor Lang, for giving such a fantastic talk, and what a great work your lab is doing. So it was a very eye-opener talk. Now we have Satish Govind from our side, who is the Chief of Non-Invasive Cardiology, Institute of Cardiac Sciences, Bangalore. He was a past president of Indian Academy of Echo and is very deeply involved in structural heart programs and one of the leading persons in the country in these things. So Dr. Satish, please. He'll be speaking on aortic paravalvular leaks.
Yeah, I need to see my slides. I think they...
We are not able to see.
Can I have my slides, please? I'd like to share. Okay.
Yes, we can see them.
Yeah. Good evening to all of you. And that was a fantastic talk taking us from the origin of echo and the way we are right now with 3D. And I think the future looks great. So I'll be looking at a very niche area. So it is paravalve leaks and a valve which is not so easy when compared to the mitral valve, but still it is very relevant in today's scenario. Now, what we need to understand is first the anatomy of the aortic valve and where it stands vis-a-vis the surrounding structures. So it's a busy slide here. So first and foremost is when we are looking at the assessment of paravalve leak, it's the location that matters. So there are two ways of looking at it in terms of cuspal location, or we are looking at the clog. So personally, I would recommend the anatomical location. Looking at the cuspal location would be much more easier to convey impressions to the others and to yourself. And you have these three valves here, so the tricuspid and mitral. And then coming to the aortic valve, you have those two big arrows. So that is where the right coronary and the left coronary arteries arise. And then going a little deeper, you have the right cusp and the left cusp, and then you have the non-coronary cusp. And then you have this clock, which goes in the opposite direction when you compare it with the mitral valve. So this is all about the anatomy and how the aortic valve looks like. Next is looking at the assessment itself. So typically we start with the 2D. So when we are looking at the PVL assessment, it's always about the location, the number of defects, look at the morphology as to what type of defect, what shape it is. Spatial information is very important about the surrounding structures and the course of the track itself. A little difficult, but some patients it can be sort of possible. And also to look at the sizing and extent. When it comes to 3D, always I think it is good to start with explain, because a lot of times this is very helpful in getting sort of simple information in a very straightforward way. So for example, here you have a posterior leak and cutting across in the short axis, you have a simultaneous view in the long axis, and you know where the jet is coming and how to localize it. And we can also utilize the full volume, the zoom, and then the color, and then you have the crop and the MPR and the multi-slice, very sort of infrequently used, but these are options that are available to us. So when it comes to the sizing of the aortic valve, which is the most important thing, so the usual sort of approach is to always, the accuracy is going to be much better with MPR. So if at all, as and when it works. And one can also look at the explain also, and to some extent the 3D image, which sort of gives you a rough idea. And when we use the photo, the transillumination, the defects suddenly start to come to life, and you start to understand the defects much more closely, as you can see here. So the two arrows points towards where the defect is, and you have these points sort of, looking at the margins of it. And then the lower image shows the color which is interposed over the defect. Next is looking at complex lesions. And this is where I think the 3D really helps in understanding the lesions. And this sort of makes the planning for, whatever intervention that is going to be done. And for the interventionalist, at least it's going to be a big sort of boon to look at what kind of lesion they're going to look at. So here you can see that it's a complex lesion. So two defects over there. And then use of the photo illumination provides us a little more insight into what is the quality of the tissue around it. So you can see that it's a very sort of floppy, sort of fragile tissue over there where the defects are. And this is what the incremental information 3D provides. Another look at a different type of complex lesion. So here you can see that the jet is coming through the defects. And what you can sort of really appreciate is that there are multiple septations. And again, you have these septations where you have a larger defect in between. And again, a planning can be done, whether it's going to be two devices or whether it's going to be one device, or where the wire is sort of going to come through and where the first device is going to sit if the two devices are going to be used. So this is, again, very sort of invaluable and incremental information provided when looking at the type of lesions. So if one looks at 3D in the aortic paravalve leaks, so you have challenges. So one is it's a very small imaging field when compared to the mitral valve. So you have the LVOT and the aortic valve. And very frequently you have these dropouts which are there, and that is going to be quite a task sometimes to get around it. And of course, you have these artifacts, which also comes into play, especially if there are mechanical valves or if there is a DVR. And then looking at sort of advising you in terms of tips. So again, the usual approach is by zoom mode, and also as a fallback, a full volume, and again, with and without color. And it's always better to use color flow to correlate to identify defects. Sometimes you have a lot of artifacts coming from the color. So identifying the defect and the color coming through it. And if it becomes even more challenging, one can look at the 2D also. So this sort of enables us to be accurate in terms of assessment. Now, once we know what the lesion looks like, now it's all about how the intervention is going to be. So looking at the characteristics of the PVL. So here it's all about the device planning. So as far as the leak is concerned, there is an aortic side, and then you have the ventricular side. So the shape can be different on either side. So you can have a different shape at the aortic side, and it can be a funnel shape, for example, and it can taper down. And at the LV side, it can be much narrower. And you can have the size also sort of different. And then more importantly, the track also. So this is where the real challenge is. And many times we sort of get into situations where it is very tortuous and very sort of serpiginous. And when we have these septations, they can be very tricky in terms of even wiring the defect itself. So before sort of doing this, if you have some knowledge of what we are dealing with as far as 3D is concerned, it makes it very useful. And when you're looking at, which defect to close and which not to, so you have these favorable and unfavorable ones. So the unfavorable is where the 3D sort of gives you incremental information in terms of the morphology, the type of the defect itself. And looking at a patient here, so here this is a bioprosthetic valve. No significant stenosis, and there was a significant paravalve leak. Cause was not known. And again, going through the standard protocol of looking at these leaks, we start with the 3 standard views, and of course, any off-axis views are also welcome. And it's always going to be a 2D and then the 3D, and then with the color. So we go through these sort of protocol, and then so when we sort of start into this mode, we are able to sort of identify where the defect is. And in this case, the defect was identified at the left coronary cusp. And once it was done, then it was looking at the morphology. So again, just adjusting a little bit of gain. So it was a crescentic shaped defect, and only one defect was identified, and it was close to the left coronary ostium. And also looking at the 2D, so there was a little bit of a floppy, the aortomitral intervallar fibrosa. And the size, of course, roughly around 15:5. And again, this was combined with the MTR and the X-plane. And at this point, the intervention was done. So this is in the cath lab, and where again, a simple sort of approach in terms of X-plane can be very useful to guide where the wire is going to go, or the catheter is going to go. And then this sort of gives a lot of comfort to everybody around, especially the interventionists, to know where exactly they are wiring the defect. And then putting on color, and again trying to find out how much of color is changing, and a lot of things can be done using these sort of small techniques by X-plane. And then again here predominantly done in 2D, but you can see that the device has been sort of released, and then you have the paravalve leak which has come down, and all in all a very sort of successful outcome. And this is one way of looking at how a paravalve leak is closed. But when it comes to intraprocedural guidance, when it comes to 3D, it has its roles now and then. It cannot be used all the time, unlike the mitral valve, where it is more often used. So it can be used in the aorta if it is of any values, to look at the catheters. But more importantly, it is to look at the aortic valve itself as to where that defect has been wired. And if at all, we can go closer to the defect itself as to whether the bigger defect is wired or the smaller one. And then again, once it is past the aortic valve, so it is in the LVOT, and then again looking at the course into the left ventricle in terms of the mitral valve, or whether it is close to any of the other structures. So this is where, to some extent, it gives you spatial information. And again, once the device is deployed, it may not be sort of as good as these images all the time, but one can definitely get sort of images where one can look at the devices very closely and look at where it is sitting, and especially when these are mechanical sort of valves, where how close it is to the discs. So that is where the really big advantage as far as the stability and the positioning of the valve is concerned. So this is where 3D is useful. So to conclude, so you have 3D over as a tool, which is invaluable, especially for difficult lesions. And what it does is it makes the outcomes better, and it reduces the procedural time and also the fluoro time. But when it comes to challenges, you have very small imaging field, and then it's very important that we correlate always with the color flow to make sure that we don't identify color artifacts. And these can be difficult with mechanical valves, the artifacts, and also it can become sort of even more challenging with double valve replacements. And also, sometimes wires and catheters can be lost as it courses around, and the tips also may not be seen very clearly. But all in all, so if one is going to use 3D in aortic parallel leaks, one can use this protocol of looking at X-plane, looking at the zoom mode, full volume, and then looking at dual imaging, and then use of various tools like cropping, MPR, and alternating between 2D and 3D. But the bottom line is 3D works, and only when the 2D images are good. Thank you.
Well, thank you very much, Dr. Govind. That was a great talk. Doing, of course, taking good 3D pictures in the aortic position, patients many times with prosthetic valves, is not easy, and you have shown unbelievably beautiful images. So congratulations to you. So we are now going to move. So how do I do this now?
Next is Eric.
I have to share again. Option. Yeah. Okay, so it is my pleasure now to introduce to you Eric Cruz. You today will see both Eric and Megan are two unbelievable sonographers. We've been working together for over 10 years, and they are the ones who truly have helped develop a lot of the technique of 3D echoes and many of the things that we have seen. So I don't think there's nobody better than Eric, who is the manager of our echo lab here, to talk about 3D echocardiography tips and tricks.
All right, well, thank you and good evening, or we should say, if everybody was here, we would say good morning. It is a pleasure, and I'm honored to be able to speak to you about 3D echo, some tips and tricks. So kind of as we start, the way that we kind of approach our 3D acquisition is I'd like to simplify things and really kind of talk about just 3 fundamental steps for every acquisition. And so the first thing that you'll have to kind of assess is really the mode of acquisition. And so there's a bunch of different types of modes of acquisition that are commercially available. We will primarily, for this talk, just focus on 3D zoom and kind of full volume or wide volume. And then kind of next, as we're processing this, we talk about 2D image. And as we just mentioned, 2D images are critical for good 3D images. So we want to make sure that we're optimizing our 2D images before we're utilizing 3D echocardiography. And then lastly is just in terms of our image acquisition, which includes our cropping or our rendering. And then of course, orientation is also key, especially if we're going to be doing some procedural guidance. So some of the modes of acquisition that are commonly used, the narrow volume is really, I'm not going to talk too much about this, but narrow volumes, we do utilize this to kind of give a little bit more depth to our 2-dimensional image. If we need to see guide wires a little bit more. But the thing to take away with this mode of acquisition is really just looking at the data set and realizing that this is a much narrower acquisition of the entire 3D data set. And then most commonly, as we assess valvular assessment for prolapse and things of that nature, we utilize 3D zoom. And again, this is really not too much different than a 2D acquisition. in the sense that we look at a region of interest much more small, and we're focusing on valves for 3D zoom acquisition. And then lastly, we have the wide angle or the full volume acquisition, and really we utilize this for chamber quantification. So the main objective here, we kind of just to simplify it, 3D zoom is when we're talking about utilizing it for valves, and full volume when we're talking about chamber quantification. So we're left ventricle, left atrium, and right ventricle, as we just took an observation of. So again, narrow volume, a really narrow interest. We'll just go on to the 3D zoom. So 3D zoom, again, this is a really nice example of a mitral valve. From the left atrial perspective, we can appreciate the prolapse. And so the main thing that we would utilize this for would be for valvular stenosis, perforations, flails, things of that nature. But again, appreciating just how small this data set is compared to the entire 3D data set that an ultrasound transducer can acquire, it's specifying one smaller region of interest. And as I mentioned, indications would be for flails or prolapse. We look at perforation, mitral stenosis. The good thing about utilizing 3D zoom as well is that it's less prone to artifacts because it's a much smaller region of interest that we're really focusing on. The one thing to be cognizant of is when you're acquiring a 3D data set using zoom is to make sure that you're including anatomical landmarks such as the aortic valve, which is appreciated at the 12 o'clock position here, and then the left atrial appendage, which would be to the left of our image here. And I think that this is important just to call out as we talk about procedural guidance, is because a lot of the times you can have the left atrial appendage be ligated. You can also have mechanical valves or repairs that make things much more difficult to assess. So as I mentioned, valvular assessment, you can do it just from a three-dimensional perspective, whether you're appreciating it from the left atrial perspective. But something that we've kind of done a lot more too is just actually looking at numbers that are related to the mitral valve annulus, such as the anterior and posterior diameter. As Dr. Lang mentioned, we can appreciate the saddle shape and the changes related to that depending on ischemic event and things of that nature. So this becomes as complicated as you want to be, but remember that this is done utilizing a 3D zoom acquisition. Next, we have the full volume. So as I mentioned at the beginning, you really want to utilize a full volume acquisition when you're looking for chamber quantification. Now here at UFC, we utilize this pretty routinely as it relates to the left ventricle and the right ventricle. Utilizing a full volume, as you can see, gets you a much larger region of interest. If you look at the entirety of this data set, you can see just how wide that acquisition is. So if I draw your attention to the image on the top left, we're getting an apical 4 chamber. If I draw your attention to the right, this is almost like a 2 chamber, but it's a orthogonal plane, so 90 degrees. And then lastly, on the bottom left, you can appreciate the short axis of the left ventricle. And I like to call out at this time that the image on the bottom left is kind of when we do a quality check. We'll talk about artifacts here in just a second, but really when it pertains to assessment for artifacts, we utilize the short axis view on the bottom left to make sure that we have the entirety of the chamber that we're going to assess. So as I mentioned, chamber quantification, this is something that's also commercially available, but just with one single acquisition, we're getting a three-dimensional size of the left ventricle in this case. We're also getting an ejection fraction. There's been much talk about longitudinal strain and circumferential strain, but the thing to take away here is that this is just one single 3D acquisition that we're allowed to get all of this valuable information. So I think that in the future, we'll definitely see this pretty routinely by the sonographers and published much more frequently. Now, one of the tips or tricks that I want to emphasize mostly out of all of this is the difference between a single beat and a multi-beat acquisition. Now, essentially for a single beat acquisition, we're just taking one cardiac cycle to build the entire data set. So if you look at the image on the left, we're getting the left ventricle, the right ventricle, and the atrium. Well, when we look at the image on the right, we can see just the impact of utilizing a multi-beat acquisition. It's essentially taking 4 cardiac cycles and stitching those together. So what is the benefit of using a multi-beat acquisition? Well, we're able to get a much higher frame rate, as I'll show here in the next slide, but it also allows us to get a much larger piece of the data that we want to acquire. However, I will mention that we should be aware of some stitch artifacts. So a real easy representation, the difference between a single beat acquisition is on the left and a multi-beat acquisition is on the right. And appreciate the frame rate difference, mainly about 4 times the frame rate as a single beat acquisition. I should mention that a lot of commercially available software that were utilized for chamber quantification warrants the use of at least 20 Hz. So that's something to utilize the multi-beat acquisition to really help increase your frame rates. And some illustrations or some examples of what stitch artifact can include, illustrated by the red arrows, whether it's a piece of dropout of the data set or kind of a line, a railroad is also something that's referred to with the 3D artifacts. And this is an example of how that data set is actually stitched together. As I mentioned, there are challenges with 3D acquisition. Be sure to have a proper ECG tracing. Make sure that there's quality from a 2-dimensional image. And the reason for that is we appreciate dropout as illustrated by the hand here. This is an RV acquisition. This does not include any of the endocardial definition of the RV free wall. So we'd be missing out on an acquisition or data from that specific part of the 3D data set. So as we touched on, good 2D equals good 3D, and you can appreciate the endocardial definition quite nicely. We can also talk about some of the cropping. So cropping can be a little bit more complicated, but in terms of a principle, just understanding the difference between the X, Y, and Z axis, the Z axis giving us the depth. And I'll close out by just illustrating an easy way to crop is now commercially available. You can just take 2 single crops, circulating your region of interest and drawing that down. And you can appreciate the image on the bottom right, the mitral valve. And lastly, don't forget about the orientation, transthoracic and TE, aortic valve on top, and the mitral valve on bottom. And with that, I will close.
Thank you. Good. Thank you, Eric. So next we invite Dr. Rahul Malhotra. He is the Chief of Non-Invasive Cardiology and Clinical Cardiology at Artemis Hospital, Gurgaon, India. So he'll be talking also on some of the scallops or so though. So Rahul, please.
Very good evening, everybody. Thank you, sir, for this opportunity to present in front of the great pioneer in 3D echocardiography, Dr. Roberto Lang. I must confess that I had the honor of working with Professor Lang in his lab for a very short period of time, but learned tremendous amount of knowledge under his very able guidance. So I'll be talking about the real-time 3D echocardiography in degenerative mitral valve disease. My slides are moving.
Yeah.
So degenerative mitral valve disease is supposed to be the commonest cause of primary MR, at least in the Western world. And it is a continuum from fibroelastic degeneration to Barlow's disease, as it is called. It is a complex morphology, but it needs to be delineated very accurately with the use of 2-dimensional or transthoracic or 2-dimensional transesophageal echo, which is very difficult to do. And therein comes the role of 3D transesophageal echo, which has made this task much more easier. So when we describe the mitral valve in terms of describing in different scallops, this is the commonest classification used, the Carpentier classification, and we must make sure that we are very thorough with the anatomy of the mitral valve along with the neighboring structures which are seen, and before we embark upon interpreting the findings of transesophageal echo. although the task has been made much easier by the advent of three-dimensional echo, which doesn't require much memorizing. So degenerative mitral valve disease, as was described by Mr. Adams, is a continuum starting from simple fibroelastic degeneration where the leaflet scallop is thin with elongated chordae, with ruptured chordae, with FED plus resulting in thickening of the tissue. And then the two forms form Presty and the Barlow's disease, wherein the valve is large with multi-scallop prolapse and redundant leaflets seen in the Barlow's disease. So beginning with some case scenarios, the case number one is a 65 years old lady, obese, with a history of bronchial asthma, presented with worsening breathlessness. She had a very poor acoustic window, as we can appreciate from these transthoracic images. We can make out some mitral regurgitation, which is extremely eccentric, but it's playing along the leaflets only. And we can appreciate that this is very difficult to interpret which scallop in particular is involved. So we resorted to transesophageal echo. So these are 2D images, extremely distorted images, foreshortened, very difficult to get good quality images in this lady because of completely distorted anatomy. But we could make out there was a mitral valve degeneration disease here, and we could see a scallop which was prolapsing. So this was an image, extremely foreshortened left ventricle, but we can demonstrate a prolapsed scallop as a cause of MR. But nothing more than this can be said based on these images. On transesophageal images, these are the zoom view taken. We could see in just one view, the surgeon's view with three-dimensional transthoracic zoom view, that there is a flail, triangular kind of a flail scallop seen in the location. This is the anatomical representation, aortic valve on top. The appendage is at 9 o'clock position. AML is on top towards the aortic valve. And we are seeing that as per the Carpentier classification, this is possibly a P3 scallop, which is prolapsing and causing mitral regurgitation. Resorting to the photorealistic image, which is another advancement which has come, which makes the imaging much better, and adjusting the use of trans-illumination light source, we can better appreciate this single scallop, P3 scallop, in the form of a triangular segment, which is flail collapsing into the left atrium. There's a lot of possibility with these images. These are not just frozen images. We can rotate these images. We can cut and crop these images to get a better idea. So this is the same trans-illumination of photorealistic view or the true view. And we have been able to demonstrate that this is in fact a P3 scallop here, which is clearly flail and causing MR. Again, in this three-dimensional zoom view with color Doppler, although the frame rates are low, but still we could clearly make out that this jet of MR is originating under this flail P3 scallop and then spreading laterally towards the appendage, extremely along the walls of left atrium. So this is a still view, some bit of cropping done with the multiplanar reconstruction option that we have. We could crop the extra tissue from the left atrial side and more clearly delineate this P3 scallop being flail with the regurgitant orifice also seen behind this P3 scallop. Again, a frozen image clearly demonstrating this triangular P3 single scallop. This is an uncropped image to demonstrate from a different angle clearly the scallop which is at fault. So if you compare these images with the 2D TE images that we had, we were clueless about the precise anatomy. But in spite of the poor window, we could clearly delineate the single culprit scallop here as the cause of MR. And all the decisions related to the future course of action for this patient, whether TEER would be possible or replacement or repair would be possible. Again, a frozen color image clearly showing that the MR jet originating behind this scallop from the medial side and then gushing towards the lateral side, towards the appendage. Case number 2, a 77-year-old retired Air Force officer complained of breathlessness on exertion for the past 1 month. His transthoracic echo was again having a poor acoustic window, and he was told to have a horizontal MR by the institute where he got his echo done, and he had come to us for transesophageal echo. So these are 2D transesophageal echo images, starting with the upper esophageal view. Aorta is seen here, and this is supposed to mean that we are seeing A1 and P1 scallops. Very often we try to localize scallops based on 2D TE only, but we should understand that these are very, very limited scope, and we can be extremely incorrect if we depend on these standard teaching which was done in the past. So here supposedly P1 scallop supposed to be flail. Putting color in this, it looks like this is a flail P1 scallop causing the color jet to move towards the medial side. So the jet is directed towards the septum and possibly this P2 scallop. But this is a deeper esophageal view where we can see now A2 and P2. So again, there is a flail scallop seen here, which is now P2 scallop. This MR jet is better seen here. So which means possibly either P1 is flail or P2 is flail. We can not be sure even now, or possibly both are flail. Another 2D image, this is at the bicommissural view where we can see both the papillary muscles, and what we see are the P1, A2 and P3 scallops. Here it seems that the P1 scallop in one beat is okay, but when the heart moves, in the second beat we find that it is the same scallop which is with a ruptured chordae prolapsing into the left atrium. So we are sort of confused whether it is the P1 or the P2 scallop which is flail, because it is a beat to beat variation that we are seeing in the bicommissural view. So we had to resort to 3D TE coming to our rescue. This is the zoomed view of the mitral valve, standard representation, aorta at 12 o'clock position, appendage at 9 o'clock position. And here we can appreciate, but not so clearly, that there is a scallop here, which is flail, which is P1, close to the appendage, with a ruptured chordae also being seen clearly. But in order to clarify the images further, we resort to photorealistic view, and the image becomes much more clearer. We can see a P1 scallop, which is flail, along with a ruptured chordae like a pointing finger inside the left atrium prolapsing. So no doubt as to which scallop is involved. Clearly the P1 scallop is at fault here, which is flail with a ruptured chordae also clearly demonstrated. This is another advancement in 3D imaging, the transparent view or the glass view, as we say. Sometimes it looks like just good quality imaging, gimmickry, not very useful, but here we can see that this somehow has made this much more accentuated, and we can appreciate clearly the single scallop along with the ruptured chordae, which is at fault, causing the significant mitral regurgitation. Color Doppler, again, with 3D has the limitation of reduced frame rate, poor temporal resolution, but we can see that the jet is originating from close to the appendage, skirting around anteriorly clockwise and then going towards the 6 o'clock position. So completely wall hugging jet along the walls, going clockwise, starting laterally, going medially. So again, in the photorealistic view, we can better appreciate and see that this jet is originating behind this flail scallop, which is the P1 scallop. Without any doubt, we can clearly demonstrate this. These are still images. Again, rather than moving clips, sometimes scrolling the image in different parts of the cardiac cycle, we are better able to appreciate which scallop is involved, and clearly demonstrated here in a still image. Again, the still image of the glass view clearly demonstrating single scallop with a ruptured chordae in the left atrium. Frozen image of the color Doppler, which has also been cropped using the blue plane here, shaving off the extra tissue. We are able to demonstrate that this jet is coming from behind this flail scallop. We can also tilt this image and crop this image from the other direction, again going very close to the orifice, the regurgitant orifice area, and demonstrate that this regurgitant jet is precisely coming from behind this location and nowhere else. So if we have resort to 2D TE, a lot of brain work was required, a lot of imagination, because when we are using these 2DE transesophageal planes, we need to remember the anatomy and where these planes are cutting in the anatomy if we want to interpret the anatomy in terms of scallops. But all these have been made very easy by the advent of 3D, just one image, one view, and no need of mental gymnastics. And we can clearly demonstrate that single scallop here. In this view, the P2 scallop, along with a couple of ruptured chordae, flail prolapsing into the left atrium, is the culprit. No need of taking at least 8 or 9 views. That was the teaching in the past. So 3D transesophageal echo for mitral valve degenerative disease is clearly much, much superior to 2D transesophageal echo for several reasons. The surgeon's view gives a clear perspective to echocardiographers as the surgeon would see it during the repair in the OR. Multiplanar reconstruction and now new tools like TrueView, photorealistic view, or the transparent view with the use of illumination light source, which we can increase or decrease depth wise to better produce shadowing and result in accurate scallop localization. Another case, 66 years old gentleman reported to have an extremely eccentric jet of MR outside in a small lab and referred to us for transesophageal echo. 2D images, again, this is an upper esophageal where we can also see the aorta. So possibly this is P1 scallop, which is flail here. Again, in the long axis view with the aorta in full view. This should be the P2 scallop because what we see in the long axis is P2 scallop. So this should be a P2 scallop, which is flail. Again, some confusion with the use of 2D TE. Going to the bicommissural view, P1, A2, P3, this seems like this is the P1 scallop, which is flail here. And color jet is also extremely eccentric, coming between the P1 and A2 image here, going along the wall in this view towards the medial side. Again, we have to resort to 3D image. And interestingly, in this 3D image, we could see that very clearly a small tongue-shaped flail commissural scallop, which was flail horizontal at the 9 o'clock level. Aorta is on top, appendage at 9 o'clock position, a small tongue-shaped prolapsing commissural scallop, rather than P1 or P2. This was a small commissural scallop, which was flail in this image, very clearly demonstrated with the 3D image. Again, the color Doppler demonstrating that the color is coming from behind this flail scallop. Another case, quickly to just highlight what is being said. This is a set of images which speak for themselves. And we can see that in this 3D image, a rare involvement of A3 scallop is shown to be prolapsing. Photorealistic image is much more clear, better demonstrating this A3 scallop, which is flail, which is an unusual scallop to be flail. And color Doppler, again, is rotating in an anti-clockwise direction here along the walls, extremely eccentric jet of mitral regurgitation. Very easy localization of this difficult scallop to pick up on 2D transesophageal echo. So lastly, this image again speaks for itself. This is a large mitral valve with multiple scallops which are prolapsing. And this is an example of Barlow's valve, which has been described. And this was an image from a patient from coming to us from the Central Asian. So to summarize, 3D echocardiography for mitral valve disease is very useful for detailed assessment of anatomy. Analysis of mitral valve motion is possible quite accurately, is reproducible. There is less inter-observer variability because of the very clear demonstration of anatomy. We get a lot of mechanistic insight into pathophysiology of MR. Decision-making nowadays in terms of intervention, whether this patient is amenable to TEER or will require mitral valve repair, is possible. In most of these cases, TER was being considered, but because of the scallops involved, we could demonstrate that this was not likely to be a good case for TER, and the patients were taken for mitral valve repair. So 3D shows us pictures as it is. There is no need of mental imagination, mental reconstruction required. And that is why 3D is the order of the day. Thank you so much for the opportunity, and thank you for patience.
Any comments by Professor Lang?
Thank you very much, Dr. Mehrotra. That was a great talk. I think showing how 3D has truly revolutionized our ability to visualize the mitral valve and to do procedures there. What we see with 3D, we can never have sort of visualized with 2D. So it is my pleasure now to introduce Megan Yamat. She has been also working here in Chicago for many, many years, has developed a lot of things in the imaging of 3D. She's the senior sonographer and she is the educator in our lab and has been teaching 3D. And she will show you, the applications of 3D to hypertrophic cardiomyopathy that now with all the medications that we have is a very interesting sort of topic. So Megan, please, if you can connect.
Sure. Thank you for that introduction. I'm going to just go ahead and share my screen. Perfect. Everybody can see?
Yeah,
And
you
we're
have put it in presentation.
perfect. We're
Perfect.
going to go ahead and get started. So we're going to do a full hypertrophic cardiomyopathy assessment by echo. Very briefly, we're going to review the symptoms. So we see shortness of breath in these patients, fatigue, exertional chest pain, syncope and pre-syncope, and of course, palpitations. So one of the complications associated with HCM is increased wall thickness. However, we see a vast array of wall thickness in different disease states. So here we can see increased afterload from a patient who has aortic stenosis, hypertensive heart disease. So we have to think if the hypertrophy is occurring based off of these conditions, or is there an infiltrative process going on with the patient where we can see amyloid? Here we can see the cherry on top from our strain analysis. Or is there a storage problem going on with these patients, as in Fabry's disease? So looking at the wall thickness based on echo alone can be a little bit difficult to determine what is going on with the patient. So very briefly, we're going to review the phenotypes, and then we're going to go into some real life examples of these phenotypes. So the first one is going to be your sigmoid septum, in which we can see this sort of basal hypertrophy in the interventricular septum. Here we can see our SAM here occurring in our peristernal long axis view, and again, the sigmoid septum in our apical views. Then you can have your neutral septum phenotype, in which the septum itself remains to be in the neutral position, so just midline. Then we have a reverse septum where it appears as if the ventricle is almost D-shaped, and here we can see an example of this from real life. Then we have our apical septal variant, in which the hypertrophy predominantly occurs in the apex, as we can see in these examples here. So it's very important when assessing these patients to do a systematic approach. So the first thing you want to do is assess your LV structure. We want to look at wall thickness, your septal to posterior wall ratio, and your LV morphology. So looking at the different phenotypes as to what is going on with these patients. The next thing that we want to do is we want to assess your mitral valve, including your submitral apparatus. Is there presence or absence of systolic anterior motion? Is there SAM-MR, as we can see in this particular example down here? And also, this is one of the best utilities of M-modes. Sometimes we can see patients who have difficult windows from a peristernal sense, but if you perform your M-mode, you can see whether or not there's presence or absence of systolic anterior motion. In addition to that, we can assess and visualize whether or not there is mid-systolic closure of the aortic valve. So these are two great utilities of utilizing M-mode for these patients, especially in patients who have poor acoustic windows. The next thing we want to do, which is one of the more difficult aspects of assessing these patients, is assessing where the level of obstruction is occurring. And your color Doppler is essentially going to steer you in the direction as to what is occurring with the patient. Again, sometimes it can be difficult to assess whether or not there is SAM from our 2D images, but with our color Doppler assessment, we can see the region of flow acceleration. So the first thing we want to do is we want to determine whether or not it's an LVOT obstruction. Is it a mid-cavitary obstruction? What is the mechanism for the obstruction occurring? We want to assess our peak gradient. And last but not least, which is the most important, is the use of provocative maneuvers. So one of the things we want to do is, if we can look at this example here, is we're essentially going to map down with our pulse wave, assessing where the gradient is, both at rest and with the use of provocative maneuvers, aka Valsalva. So here we can see on this particular patient, we had a resting gradient of 43 millimeters of mercury, and we increased it to 200 with the use of Valsalva. Sorry, 1 second. And so here we can see, again, just sort of honing in on the resting gradient. And here we can see our Valsalva. So we want to assess this in multiple imaging planes. So I'm sorry, let me backtrack. This sort of advanced my slides. Okay, so when we go here, this is actually a real life example. We're going to go through a couple of studies to show and demonstrate the challenges with assessing these patients, because we know that there are challenges that can occur. So here we can see a small ventricle, pretty hyperdynamic ejection fraction. We can see systolic anterior motion of the mitral valve. As we look at our color Doppler assessment, we can see there is flow acceleration. And as we look at our CW Doppler, we can see there is an outflow tract obstruction gradient, but very minimal. However, when we go to our Valsalva and we induce that sort of gradient, we can see that the gradient has increased significantly. So the other thing we need to do is we need to assess this gradient from multiple imaging planes. So now we've moved to our apical 3-chamber view, our apical long axis, and we've obtained a gradient, max gradient of 59 millimeters of mercury. When we do Valsalva on this patient, we obtain a gradient of 140. Now, one of the most common things that we see and one of the obstacles in assessing these patients is jet contamination. So if we look at this, this is a very, very subtle difference. This is a patient I just did last week. So here we can see a dual sort of image format, looking at our 2D image along with our color image assessment. And so one of the things I wanted to make sure is that this wasn't being contaminated with our MR jet, because we could see that the actual velocity was approximately 6 meters per second in keeping with mitral regurgitation. However, we want to make sure that it is in fact mitral regurgitation and not the actual gradient. So it's very, very subtle. I'm not sure if you can see the difference, but what I'm going to do is now magnify this. So what I did is I took a resting image on this left-hand side. So we can see at baseline, the patient has very, very minimal MR. When we use the provocative maneuver of Valsalva, you can see that we've increased our MR jet by approximately 50% compared to at baseline. So now we can confirm that this is in fact our MR jet. Now we talk about using the provocative maneuvers and Valsalva maneuver on our Doppler images, but it's also important to do so on your actual 2D image to see what the mitral apparatus is doing, as well as your color Doppler assessment. And so here again, we can see the true gradient on the left-hand side. This is the contaminated mitral regurgitation. And if you do your baseline assessment, when I went back and I re-imaged the patient, I went through all the imaging planes, you could see that the patient only had very minimal MR. So it's important to use the provocative maneuver and do so with your color Doppler assessment. We're going to go in through some other case examples here. Here we can see the septal wall thickness appears to be thick in comparison to our posterior wall thickness. As we look at our color Doppler assessment, we can see that there's minimal AI, doesn't seem to be any flow acceleration. We do our M-mode assessment of our aortic valve. We don't see any apparent mid-systolic closure, but again, in keeping with a thick septum at the basal portion. We then move down to our apical views, apical 5-chamber view, and we can see very minimal flow acceleration here. So I'm just going to pause this and sort of scroll through the image. Very, very subtle, but we can see a region of flow acceleration here. We can see as it's accelerating here. So as we proceed on with the exam and we again pulse and sort of track through, we can see here's a tiny little minimal amount of late peaking gradient, but we're only obtaining a gradient of 15 millimeters of mercury. Now, if we just stopped right there and said the patient has no gradient whatsoever in this case, as we use Valsalva maneuver, we've obtained a gradient of 63, which now makes the patient eligible to be on mavacamten. So it's all about using your maneuvers and properly interrogating these patients. The other thing that you want to keep in mind, depending on the different phenotypes that you're dealing with, in this case, here we can see nothing too apparent. This is a patient with difficult images, but we can see overall preserved LV systolic function. As we use our ultrasound enhanced agents, we can see that there is this sort of apical outpouching, sort of apical aneurysm noted here, which is very important, especially in the apical variant phenotypes. We want to make sure that we use contrast on these patients. And here we can see polar opposite to the examples that we saw earlier on, as where the hypertrophy occurs mainly in the mid portion of the ventricle and towards the apex, whereas the basal portion appears to be pretty preserved in wall thickness. We can see that there is no systolic anterior motion of the mitral valve. There is no SAM-MR. And as we get down to our apical images, we can see this apical wall motion abnormality here. And again, we're going to use our color Doppler to guide us as to where this gradient is occurring. So as I scroll through here, we can see this area of flow acceleration here. So we know exactly where the gradient is occurring. So we looked at the different gradients occurring in the LV outflow tract. This is a great example of looking at this sort of mid-cavitary sort of obstruction. So again, mapping out the gradient from your pulse Doppler, you want to start in the area where you expect to see this sort of laminar flow. So we go up here to where the apical aneurysm is here, and we pulse, and we can see that there is no, in fact, flow acceleration. As we start pulsing down into the area or the region of flow acceleration, we can see the sort of late peaking gradient coming out. And as we get into the meat of it, we can now see that we've hit our Nyquist limit. This is, in fact, mid-cavitary gradient. Very, very minimal. We could see at rest, we had a gradient of 79 millimeters of mercury, and incremental increase of Valsalva to 87. But I just wanted to use the provocative maneuvers in these patients because you might not see a baseline gradient, and you might be able to obtain that gradient using Valsalva maneuver and maybe not even have to go on to the stress portion. And so one of the things we talked about is looking at 3D. So 3D utility for this particular patient population is important because we have the ability to calculate 3D ejection fractions in these patients. And tracking their ejection fraction is very important, especially with the use of these patients with this medication because they can have an EF reduction. So you want to make sure to do an accurate assessment on your EF, especially if you're borderline from your 2D images. You can use your 3D ejection fraction as your sort of tie. And we talked about the use of transillumination. So here we can see a true view rendering. This is something I do utilize for looking at wall motion abnormalities because you can sort of introduce this light source and illuminate specific areas. But in addition to this, if you are to obtain a 3D full volume data set, and maybe we don't see this thrombus on our 2D images, if you track through on your MPRs offline or either on CART, you can have the ability to find out whether or not the patient truly does have apex because it eliminates the geometric assumptions. And so if hypothetically, you're in a foreshortened window, you can move your planes and make your planes in the correct true apex of the left ventricle. So in this particular patient, and that we can see that there was apical akinesis, but in addition to that, the patient had a clot here at the apex. So in closing, just have a systematic approach when assessing these patients, introduction of 3D for 3D ejection fraction, as well as if you're not sure if the patient has a clot, you can go through on your MPRs and assess whether or not you're in the true actual long axis of your left ventricle. Thank you very much.
And then over a short period, you have given an excellent review of the whole of this hypertrophic cardiomyopathy, which we could not believe, and such great images. I think they are as good as you look. So they are great images, and I heartiest congratulations for such a wonderful presentation. Thank you very much.
Thank you.
Thanks. So now we invite Professor Vijay Lakshmi, who is the Professor Emeritus and former head of the Department of Pediatric Cardiology at Jayadeva Institute of Cardiology, and she is the past president of Indian Academy of Echo. So, and a very, very great pediatric cardiologist of our country. So please, your presentation, please. He will be talking on both congenital and acquired VSD. Can you enlarge your image?
Yeah, open now. Share.
Yeah, please.
Just 1 second, sir. 1 second.
But try to finish in 10 minutes.
Sir, yeah. Yes, sir. Can you sleep my slide, sir?
Yeah, yeah.
Yeah. No, full screen. So good morning to the friends in US and good evening to all our friends here in India. As a pediatric cardiologist, I would like to talk about the 4D echo, how it can improve my efficiency and giving the higher success rate. Recently added 4D echo has added advantage in decision making for the interventions in challenging cases, for the diagnosis and the successful transcatheter device closure of all the conditions, especially the ventricular septal defect when they are challenging. With the technological refinement and advancement, one can see the echo in 4D. The time is the fourth dimension and see the motion in a single beat as well, as if we are looking into the heart from any side, any angle, and it is amazing. 4D echo is the real-time motion of the heart that is described as the fourth dimension, hence it is called the 4D echo. 4D is the real 3D with no cutting, no cropping, and no workshops to learn. And here you can see that this is the 2D and that is the 3D.
Excuse me,
But
ma'am.
what is more important is
Your slides are not moving.
You have to come to full screen mode.
slides are not moving. Slides are not moving here, they're saying.
And you have to come on a different mode to
Slides are not moving, they're saying.
To full screen, ma'am.
Can you see my slide?
You can see it, but they are not moving, ma'am.
come to the next slide, slide number 2.
Okay, now is it
Please
changed?
go to, ma'am, please go to slideshow mode. It's not slideshow.
Slideshow, no? Go to the slideshow. Here?
Yeah, I went on.
Or this one?
Yeah. No, that.
Come here now.
Now, can you see me? Can you see my
Share
slide
again.
moving?
No,
Okay, is it better?
we don't see it.
You're not seeing?
No,
1 second,
because
sir, 1 second.
during the drive run, your slides were very well seen, but I don't know what has happened today.
Now, can you see, sir?
Yes, sir.
Yeah,
Yes, ma'am.
Okay. Okay. In the
But-
past, whenever we used to put the device in the animal study, they used to do the autopsy and to see the endothelium. Now you can see that 3 months after the device closure, a very nice endothelium is grown, and we can see from the RA side as well as the LA side. Now, I would give you an example of the 56 years old man with the acute myocardial infarction in a cardiogenic shock. And the 2D echo in the parasternal long axis view showed ventricular septal rupture in the apical region. So in the apical fourth chamber, you can see that the whole the apical region is aneurysmally dilated, thinned out wall, and the rupture in the interventricular septum at the apical region. And with the color Doppler, we could measure it as 12 millimeter. So I decided to close it with the 16 millimeter device, knowing fully well that this closing the ventricular septal rupture can be very challenging. So here the problem is the irregular shape, the fragile tissue, and the location of the defect potentially leading to incomplete sealing. And the device embolization is very high, and the complications like valve damage are also there. And that is the reason I thought of doing the 4D echo in this patient who was very sick. And look at here, the on the LV side it is oval and it is very huge. So if you see the LV side, you can see that it is literally 22 millimeter by 18 millimeter, almost the double the size of what I saw in the 2D echo. And then when we looked at the RV side also it is very huge oval and it was almost 24 millimeter. So now you remember, If I had to take the 16 millimeter device, it would have embolized and we would have put the blame on the fragile tissue which has yielded. But in reality, we had underestimated the size of the ventricular septal rupture and also the tissue that is coming in between. And that too, we have to go through the jugular approach for the apical region. And especially when it is more than 50 millimeter, putting a large device of 24 or millimeter device with the 34 millimeter retention skirt through the jugular approach will be very difficult in such a sick person. So now we move on to the second patient. This is the 4 years old boy with a small high muscular VST. Anybody would think that it is a very easy one, because high muscular small VST device closure is very easy. But then I saw in the LV side and the RV side, and to my utter disbelief, you can see that the septal leaflet of the tricuspid valve is wobbling between the right ventricle and the left ventricle. So when the tissue is wobbling like this, if I cross the VST and try to put the device, and this tissue will be caught in between the two retention skirts of the device, and the child will develop torrential ventricular septal torrential tricuspid regurgitation. So this is how we know the clarity of the VST and the complications can be made out with this sort of device. So this is the third case, the 3 years old child with a severe pulmonary stenosis and a small perimembranous VST. On a 2D echo with the color Doppler, the VST measured 4.6 millimeter, and that is very easy to close. So I thought I will open the pulmonary valve and then close the VST with the 6 millimeter device. But to my utter surprise, when I did the balloon dilatation and then did the LV angiogram, there was no VST. The echo, 2D echo has shown the VST, and how can the VST be disappeared after the balloon dilatation? So I went to the 4D echo, and here you can see that you can see the VST very clearly from the RV as well as the LV side, but in the real picture, it is better than a surgeon's view. You can see that during the systole, the VST is literally closing. So when the VST is closing during the systole, naturally no dye will come. So this case does not require any VST closure because it measured less than 2.4 millimeter on the 4D echo. So the use of 4D during the interventional procedure has several advantages compared to the transthoracic echo or the transesophageal echo. In comparison to the transesophageal echo, patient comfort is better, general anesthesia is not needed, and there is no risk of the aspiration in the small children. And 2D echo usually does not offer the adequate imaging quality to visualize the detail, whereas the 4D gives an accurate, live, real picture of the heart with all the minute details. And that's how we know the 4D echo, automated 4D echo, no cutting, no cropping, live cropping with the real-time natural image, beat-to-beat image is seen. 4D echo appears like a child's play, can see the defect from any side and any angle, either from above or from the below or from the right or the left. So the 4D echo enables easier interpretation of the images from the more realistic, better than the surgeon's view, because the surgeon is operating on the non-beating heart, whereas here the beat by beat normal natural color is seen. The high quality near field images of cardiac structure allowing the operator to work with the patient's anatomy rather than fighting with the anatomy. And that's how I would say, conclude that 2D echo looks like the bird diving inside black and white. 3D echo gives a better clarity, but the 4D echo is excellent. It is precise and accurate. So thank you very much for your kind and patient hearing, because when we are doing the intervention in the cath lab, though it appears attractive, what happens is, unless we know the precise anatomy, there can be a crash in the cath lab, and to avoid that crash, you have to have the 4D echo to reduce the incidences of nightmares in the cath lab. Thank you very much for your kind and the patient hearing. Thank you.
Thank you very much. That was a great talk with beautiful images. Something that we encounter in our lab mostly after such a race. It is my pleasure now to introduce to you Martin Gruca. He is the youngest member of our lab. He did his training here in our place for a couple of years, and he has been working on new ways in which you can use 3D echo to quantitate mitral regurgitation. So it is my pleasure to introduce to you Dr. Gruca.
Thank you so much, Dr. Lang, and thank you so much, everyone, for inviting me to speak with you all today. Let me just pull up my slides here. Okay, and then we'll get that one. All right. So I'm here to speak about the role of 3D echocardiography in the setting of transcatheter edge-to-edge repair. And so currently, what are some of the advantages of 3D echocardiography in this context? We've covered some of these already, but just to briefly review, one, obviously 3D echocardiography is spectacular at being able to localize pathology quickly. Here's an example where you can kind of tell from the size of the left atrium, right? You have a small left atrium, and actually in this case, you had a very small echo window. And you can see that there's this thickening of the valve, and you have this severe MR jet that seems to be originating near the commissure, near P3. But you don't really see the whole picture here. When you do get to do a surgeon's view 3D acquisition, you can see that there's something much more that was missed on those images. This large vegetation as a central cavitation. As we've seen in some of the other presentations, you can utilize or exploit virtual light and shadows to try to emphasize different features. And then you can even turn the color back on and see that indeed that vegetation is the source of the regurgitation. So this is a vegetation with perforation. It's good at guiding delivery systems, especially since these are more echogenic than the surrounding tissue. So if you turn down your 3D gain, you can see exactly what the orientation of the clip of a mitral clip is in relation to the commissures, whether it's too lateral or too medial, and whether it's facing the mitral valve. Using multi-plane view, you can use, even in live 3D acquisitions, you can decide to move your planes at exactly the point that you want. So in TEER procedures, obviously it's very nice to go to the mitral valve tips to determine the mitral orifice area. And here you can see that for a mitral clip, it's 5 square centimeters, which is plenty of room where you don't have to worry about potentially causing stenosis. And in this case, this is a very beautiful case of rheumatic mitral stenosis, and obviously being able to determine the mitral valve area at the tips is critical for determining how severe the stenosis is in these cases. And as Dr. Lang mentioned in his presentation, in the emerging age of tricuspid TEERs, these are even more amplified in their utility, because 40% of people, their tricuspid valve has 4 leaflets. In this case, you have the septal leaflet, and then you have a P2 and a P1 over here, and you can see that there are various leads here and an anterior leaflet here. And given the variability in tricuspid anatomy, and given the fact that you have to kind of describe a complex relationship between leaflets and leads, 3D is very helpful for that purpose. And multi-plane view can also help you localize to particular structures and help you get annular areas that are useful for the evoke valve replacements. So an interesting case that we had was a 67-year-old man with seizure disorder, prior intracranial hemorrhage, admitted for atrial flutter, found to have severe MR. And you can see on the 2D images that, there is quite a bit of thickening degenerative changes in both the anterior and the posterior valve leaflets. You have a jet of severe MR and malcoaptation here. When you start searching around, you can see actually this small ruptured cord. And you can see on your bicommissural view, you see the cord again near maybe A1, P1. And you can see that there's marked thickening across the valve. And when you turn on color, you see that there's, either there's severe MR that extends across the leaflets or that there's multiple jets here. And this was a case where the 3D really kind of very quickly tells you the whole story. You can see that this is a beautiful case of Barlow's disease, where you have marked thickening of both leaflets across all the scalps. You can see this A1 flail segment. And furthermore, with color, you can see that there's two distinct jets. There's one that's originating from this flail segment, and the other that's originating more centrally from A2, a P2. And so this person was referred for a TEER device. You're able to help steer their catheter to say that they need to go clockwise. And once they do, you can see that the orientation is correct, but that the flail segment is still lateral to the clip. So you can tell them, okay, advance your catheter so that you actually get the pathology within your clip. Here it's at the correct position. You can see that they're able to advance in the LV cavity and they're able to grasp the anterior leaflet in this view. And then as they close, you see that there's marked reduction in the MR, what looks like trace. Now, I think we all suspect, based on the fact that there are two original jets, that this may not tell the whole story. And rightfully so, on 3D, you can see that you have a great tissue bridge between A1, P1, but that on color, that 2D image doesn't represent the whole story. You still have this pretty significant jet medial to the device. And so that helps kind of direct you to tell the interventionalists that we should place a second clip medial to the device. And that's what they're able to do successfully. And then you can see that afterwards you have reduction in the MR to mild. That's where we are currently. What role might it play in the future? And we think that's a very exciting field. Obviously, the grading of mitral regurgitation is notoriously difficult and scenario specific. And even within quantitation of regurgitant volume, there's multiple ways to do it. Volumetric method, you can use pulse wave Doppler or total LV stroke volumes. And then there's the PISA method, which I think in our experience is one of the more common methods. But especially in the setting of TEER devices, that's a very flawed methodology, right? Because you have multiple geometric assumptions. For one, when you place a mitral clip, you by definition create multiple orifices in most of the cases for the resulting MR. So that violates one of the main assumptions of a singular jet for PISA. A good proportion of the people who are being sent for TEER devices are functional MR, and we all know that those people tend to have a slit-like orifice, not a circular orifice like you typically expect for the optimal 2D PISA case. And the other large proportion of patients getting TEER devices tend to have prolapse or flail segments, which typically have eccentric jets, which also is suboptimal in terms of the assumptions that you make for 2D PISA. Wouldn't it be great to have a system where you can get rid of those assumptions? And that is what we've been working on with Philips in developing this software program CFQ, which stands for Continuous Flow Quantification. And essentially what happens is you use the 3D structure of the mitral valve in the surgeon's view to basically use the color from that view to basically plot the vector field of the color data. You can use then to create multiple pinhole models throughout there, where you think where it thinks that the orifice is based on that 3D representation, to create a custom geometry for what you're witnessing in front of you. And then you can essentially track it. You can use a hemodynamic model to estimate the regurgitant orifice, and you can essentially, in an iterative fashion, reshape that model closer and closer to what you're actually witnessing on the color data. And the other thing that's kind of nice, in addition to being able to say that you don't have geometric assumptions, you don't have to worry about how well aligned you are with the jet, you also have a more dynamic understanding of what's going through the mitral valve. I think we all have a respect for the fact that the mitral valve is a very intricate structure that changes throughout the cardiac cycle. Wouldn't it be nice to be able to track the regurgitant orifice across the cardiac cycle frame by frame, rather than just assuming it's static? according to what the maximum regurgitant area is. And that's precisely what this program allows us to do. You have vectors across frame by frame, and thus you can actually track the orifice frame by frame as well. And then in this case, we have a case of severe functional MR, where it's not playing, unfortunately, my apologies, but severe functional MR, you can see that as it's going across frame by frame, this pink area is basically where the software tracks the flow convergence. And you can see that despite the fact that it's a slit-like orifice, it does a fine job at it. And as a result, you're able to also quantify the regurgitant flow in each frame. And you can see that for functional MR, it even replicates the bimodal shape curve that you expect for this physiology. If you do a mitral TEER device, then you can see that here there's multiple jets that are actually being tracked by the software, which is also very helpful in the setting of TEER. And so we thought that would be a very interesting context to test out this software. And so it's a very small pilot study thus far, but we had 5 patients where we did this quantitation before mitral clip and right after the placement of a mitral TEER. And essentially, these were people who got the TEER because the echocardiographer felt like, yes, there was in the holistic assessment, there was an improvement in their MR. And in 4 of the 5 patients, we did see a decrease in the regurgitant volumes measured by this methodology. The orifice area in all of the patients decreased with this assessment. So we actually prepared this as an abstract for the upcoming American Society of Echo in September. So we're excited to hopefully present these results and hopefully study this further. Thank you so much.
Thank you, Martin. I think this type of work is only expected from the lab of Professor Lang, which is one of the internationally recognized labs or so. I'm sure it will be very interesting for the future, and we'll also see it during the ASU 2025. So thank you very much for this excellent presentation. Now we come to the last presentation, which is a very important one by Professor Amuthan. He is a former head of the Department of Cardiology at Madurai Medical College. He is a director of 4D Echo at a very prominent heart center in Madurai. He is a past president of Indian Academy of Echo. And the thing is that he is the first person who authored a textbook of 3D Echo in this country. So he's unofficially known as the father of 3D Echo in this country. So Professor Amuthan, please. He has changed the concept of a calcified mitral stenosis. So let us see.
So please unmute yourself. Professor Amuthan, please unmute yourself. We can't hear you.
Yes, madam. Yes. Thank you for your kind introduction, Dr. Parashat sir, father of echocardiography in India, and for allowing me to present this interesting series of 2 cases. And I also thank Professor Lang, with whom we work in the waste normal study as the PI from India. So this is the small group of 2 cases where we used the use of trans illumination in Philips terms or flexi light in GE terms to identify the cases of mitral stenosis at an extremely late age with calcification who can undergo balloon mitral valvuloplasty in spite of the calcification. So the necessary views, this is the view of the mitral valve from the LA perspective. And for studying the calcification, we need lateral sections also. This trans can be taken at the medial and lateral commissures also. And we can decide whether the calcification which is there involves the commissures and will obstruct the process. So this is the mitral stenosis. Of course, this is a classical case in a young patient where there is commissural fusion involving the lateral as well as the medial commissure. Now, for the theoretical purpose, you can see the mitral stenosis can be symmetrical or it can be asymmetrical. And the mechanism of split in balloon mitral valvuloplasty and the following MR may be classed into commissural split alone in 35% of the cases approximately, and central split in 17% of the cases, and with the complications, that is a leaflet at central with subvalvular problems and posterior leaflet and TEER and other things. So the mechanism of split is central or isolated commissural with MR or commissural with the posterior leaflet TEER or anterior and posterior leaflet TEER. So this is a central MR, and this is before and after balloon mitral valvuloplasty. This is commissural with the posterior leaflet TEER and other things. So the incidence of adverse events of long-term follow-up depend on your involvement of the commissures. That is very, very important. So to identify the commissural involvement, you have to add other tools in addition to your standard 2D and 3D and 4D echo, the addition of the light, that is a flexi light. So this, you can see, this is a patient who has been treated for 20 years in a corporate setup as a case of mitral stenosis. See the poor echo window, and the lady was not diagnosed of the mitral stenosis till a late date. So she had a very tight mitral stenosis, and the ejection fraction was okay. But you can see the calcific nodule and other things. And she had high jet, measuring 25 peak and 18 mean gradient. And this is the transesophageal echo view. And you can see there is a yes. So this nodule, calcific nodule, you can see. Now we were very eager, and this lady at the advanced age, she said refused the surgery. She was not willing for the surgery. So we have to do the balloon mitral valvuloplasty in spite of the presence of the calcification and large calcific nodule. So we use this flexi light. As you can see that, you can see the lateral as well as the medial commissures were free. And this is the mitral area, which was 0.6. And the patient underwent balloon mitral valvuloplasty. And you can see that the valve opens well. It's a very good split. And the gradients reduced to a peak of 5 and mean of 2. And you can see that there is a large split, and the nodule is not at all involved. And the mitral valve area here was markedly improved. The patient was asymptomatic. The mitral valve area was 2.9. You can see here 2.9 valve area. And this is the pre compared to the post balloon mitral valvuloplasty result. Now, what happened was the lady returned after 1 year with again severe symptoms, and this time again she had increase in gradient to peak of 23 and mean of 12, and you can see that the valve area was reduced again to 1.1, and she had a very severe stenosis and died ultimately. This is a second case. This is a patient with a 63-year-old man who had balloon mitral valvuloplasty in 2011, and he returned with atrial fibrillation and calcification of the mitral valve, and you can see here the calcification is there. And this is the unusual type of calcification. The entire posterior mitral leaflet you can see has calcified, entire mitral posterior mitral leaflet, and this mitral valve area is 0.7. And this is the flexi light, use of the light. You can see that the lateral commissure and the medial commissures are well opening, except for the calcification in the PML. And this is the use of the flexi light. and his left atrial appendage, you can see that left atrial appendage is clear. There, in spite of atrial fibrillation, there was no clot. The patient underwent a balloon mitral valvuloplasty, and this the post balloon mitral valvuloplasty. He had an increase in gradient of the mitral regurgitation. This is the pressure strain loop, which you can see more concurs with mild mitral regurgitation, and the mitral valve area increased to 1.9 centimeters. You can see here both the commissures opened up. This is the calcification seen in the TML. Both the commissures have opened well, and the patient is doing very well. So these are the two cases which I would like to present to implicate the importance of adding 4D and the Flexi light for examining the patient with calcification in mitral valve who insists on balloon procedures rather than surgery. And these are the contraindications to balloon mitral valvuloplasty. As we know, Wilkinson score of more than 10, and the involvement of the medial and lateral commissures. So these are the most important thing. And a good immediate result is defined as a mitral valve area more than 1.5 square centimeter without MR. And the results and conclusions, this Flexi light evaluation of the mitral valve valvotomy for mitral valvotomy is very, very beneficial. And you can easily identify the commissures. And you can usually suggest that this patient has no calcification in the commissures, and he can undergo balloon procedures at an advanced stage. Thank you for your kind attention. Thank you. Sir, you are not audible, sir. You can unmute. Thank you, madam.
Because I could see three questions. One may be for Professor Land, that in a 3D echo strain in view of a low frame rate, how effective is to determine a 3D echo strain? You may,
Sir,
unmute yourself.
Yeah. Thank you. I'm
Yeah.
sorry.
Yeah.
We still all have to learn about 3D strain, but I would say that any type of quantitation for strain, I would like to see a frame rate of at least 30 or more, and that can be done today. I really don't know how much lower frame impacts 3D strain. We know it impacts tremendously 2D strain. So we'll have to learn some more about that.
One question is for Dr. Govind, how to differentiate this paraalveolar leak from the washing leaks? Oh, I think he has to go somewhere to give another talk, I think. So Satish Govind is not here. Then one question is for possibly from Martin, that can TEER be done for perforated leaflets with severe MR?
Say that again. I can answer for him.
Can TEER be done for perforated leaflet with severe MR?
Yeah, and what and the question is if we can do.
Yeah, suppose there is a perforated leaflet and
so
there is severe MR.
Yeah, the whole idea is, this was a patient with a vegetation with a perforated MR. And in this particular example, I don't know if I agree, but I think they tried to do an intervention because of the perforation. I don't remember if it was successful or not.
Sorry. Can you hear me?
Yeah, I can hear you well.
Yeah. There is one question, that is it safe to perform Valsalva when the gradient is when the resting gradient is more than 50 mmHg? That is for.
Yeah, Megan, are you there or did she leave?
I'm here. No, I'm here. No, absolutely. You want to perform to see what the maximum gradient is occurring in these patients. That way, when we medically manage these patients, we can see the reduction of the gradient as well as their symptoms. So absolutely, we want to promote the maximum gradient, whether it's at rest or with Valsalva.
Yeah,
So
and I
let
think
me
it,
see.
it's safe to do it.
It's safe to do it then. Then as Dr. Gobind is not here, somebody can answer the paravalvular leak in a valve in prosthetic bivalve, can it be easily plugged? Suppose it's a bioprosthetic valve with paravalvular leak. So I think Amuthan or anybody can answer this question.
Can I answer, sir?
Yes,
Yeah,
madam.
anybody.
Sir, the difference between the bioprosthetic and the mechanical valve is doing the valvotomy is difficult because it's a degenerated valve in the bioprosthetic. But a paravalvular leak can be closed whether it is the bioprosthetic or the mechanical. It doesn't make any difference because it is outside.
Oh, Amuthan, how to differentiate between paravalvular leaks and washing jets?
Paravalvular
Dr.
leak,
And
we
washing
can,
jets.
the washing jet probably is meaning the leak through the center of the valve, prosthetic valve. The paravalvular leak is in different area in the circle. So you can easily differentiate by 3D or 4D echo. When you do the evaluation for mitral valve from the LA perspective, you can easily identify the paravalvular leak which is occurring from the outer skirt of the axial valve, whereas the washing jet is the central leak through the cusp. I think Rahul will agree with me.
Yeah, come sit down.
So, on behalf of Indian Academy of Echo, we profusely thank Professor Lang and his team for this great webinar. And Professor Lang has always been a great friend of Indian Academy of Echo. And I'm sure in the subsequent, maybe we'll give him rest for about 6 to 8 months. Then we'll involve him again. So he'll always be there to help us in any academic activity.
My pleasure, and thank you so much for inviting us.
So it was
Thank
a
you,
very
sir.
session. Thank you so much.
So,
Oh.
Dr. Lang, I thought your slides were the best. As an opening batsman, you did it. Your benchmark was so high. It was difficult for us to reach. Excellent, extraordinary
So
presentation.
thank you very much. So we can now go off from this thing, and we'll get a very good feedback of this webinar. Thank you very much for everybody participating in it.
Thank you, madam.